Good evening, everyone. A warm welcome to all for today's Maha case challenge. Today is the third episode. I welcome all the dignitaries who are present on the Zoom platform, as well as our viewers who are watching it on YouTube Live. I acknowledge the presence of Maha President, Dr. Hemant Gangulia sir, Dr. Secretary, Dr. Amol Pawar, Convener, Dr. Jay Bhandarkar, Dr. Mahesh Moite sir, who is the brain behind this concept. Then I welcome our moderator, Dr. Kuldeep Sukhdeva, and Dr. Sunil Shaitsar, and of course the participating teams. The teams today are the team Navi Mumbai as well as team Amravati. And Navi Mumbai team comprises of Dr. Amit Saxena, Dr. Satish Shane sir, Dr. Mangai Sinha, and Amravati team is of Dr. Shripa Chahita, Dr. Shailesh Jaiswal, and Dr. Rohan Bogde. So I welcome all my seniors and colleagues too for today's session. So I will now invite Dr. Hemant Gangulia sir to give his opening remarks. Over to sir.
Thank you, madam. Good evening and namaste to respected experts, Dr. Thangavelu sir, two presenters, two teams, Dr. Moite sir, coordinators, Dr. Sunita, Dr. Shilpa, Dr. Renu, Dr. Ramakant in absentia, Secretary, Dr. Amol, Convener, Dr. Jay, and all Maha IP office bearers, dignitaries on the dais, and the attendees on the Zoom as well as on the Maha IP YouTube channel. Well, this is the third episode of Maha IIP case challenge. Rather, I feel it is a Maha suspense challenge session where everything is kept secret by the coordinators, and no one is aware of which team is going to participate, and teams do not know who is going to be expert unless and until the name and the expert picture appears on the flyer, as well as nobody is aware of which team is participating. That is the beauty of this session, and truly it is an adventurous academic journey of cracking the case with reasoning. So approach is very important, and we are very fortunate to have a very great academician, Dr. Thangavelu sir. Thank you, sir, for sparing your valuable time for us, and hearty congratulations to all the coordinators for efforts and fabulous efforts, as also the best wishes to both the teams as well as both presenters. Thank you very much.
Thank you, sir. Now I request Dr. Mahesh Moite sir to say a few words, sir.
Thank you very much, Dr. Sunita. Thank you, Dr. Hemant and the whole team. First of all, thanks a lot to Dr. Thangavelu sir. I mean, he's the person who is there whenever there is academics. Very simple. So you can put it the other way. If he's there, it's all academic extravaganza.
Thank
you.
Kind
of you can take. They are connected things. Academics and Thangavelu are not two separate things. They are one thing, one and all. I have a great respect for this man. I always call him as 5 DMs in one person. He's like 5 super specialists in one person. He can crack up any case. So he's the right person. Again, about the concept, whatever Hemant has already said, it's not about whether you can crack it or not. It's all about the approach towards the diagnosis. And this is more of a clinical diagnosis for the history, the clinical examination, and the labs. So you may find some clear-cut clue towards the diagnosis through one of these aspects. And that's what exactly we want to promote as a clinician on this dais. So far, we had 4 cases in previous 2 sessions. All were absolutely excellent. I'm getting great feedbacks on it. And I'm sure we are going to have the same thing. So without wasting much time, I request the organizers to continue. Thank you very much. Thank you.
Thank you so much, sir. Now, it is my pleasure to introduce Dr. S. Thangavelu, our learned expert for today's session. Sir is a pediatric consultant attached to Mehta Multi-Speciality Hospital in Chennai. Sir is former AP, Institute of Child Health, BIC Madras Medical College, and sir has an extensive teaching experience for MD and DNB students for over 25 years. He has contributed chapters in more than 20 books and has published many journal articles. And mainly, sir is an editor-in-chief of Indian Journal of Practical Pediatrics. Many awards have been conferred on him, the main being the Best Teacher and the Best Doctor Award. So this is a very short introduction. Sir is a very humble person, so for that I've interacted with him. And now I invite sir to please say a few words. Over to you, sir, Dr. Thangavelu.
Thank you. Thank you. Good evening, everyone. I'm really happy to participate in this. When you are all describing, my adrenaline is going up. Peak level is increasing and increasing. So when I thought over it, really felt how we are going to approach this. It reminded me one Zen Buddhism story. One person has to cross a forest road, a 5 miles road. It's a dark night. He was sitting in a mud and was wondering whether to walk or not. That place, one Buddhist monk comes, Zen Buddhist monk. He asked his problem and he gave a hurricane light. Take this and walk away. He said, 5 miles of dark road. How this hurricane light is going to help me? He said, this hurricane light, he said, the hurricane will give me only 10 feet light. So the monk said, when you hold it 10 feet, when you walk 10 feet, another 10 feet will be visible. When you walk another 10 feet will be visible till you reach the target, 10 feet will be. So with this story in my mind, I'm going to approach these slides. Every slide is going to give me some light through which I'm going to walk through the dark area. As you said, no, whether we are able to reach a diagnosis or not, the road in which, how we are going to select the road. Thank you very much for giving me this opportunity to face the challenging cases. Maha in Tamil also means large, big. This is a Maha challenge. Maha challenge means biggest challenge I have faced. Thank you. Thank you. Over to the...
Sir, thank you so much for the wonderful analogy. Really nice. Now I will request Dr. Shilpa Navyar to conduct the further proceedings. Dr. Shilpa, please go ahead.
Good evening, everyone. Thank you for joining today's session. So, as we know, our two teams from today are from Navi Mumbai and from Amravati, and our two moderators are Dr. Kuldeep Sukhdev sir from Nagpur and Dr. Sunil Shaitsar from Raigad. So, before we start our session, I'll just tell you some points which we have to follow. Only the moderators and the team to which the case is being presented are to be on mute. All the others, please keep yours to be on unmute, and all the others, please keep yourself on mute. Do not post any answers on the chat box. In case there are any questions or discussion, we will have it after the expert comments, and each case will be given around 25 minutes time with 5 minutes of discussion for it. So to start our today's first case presentation, we will start with Dr. Kuldeep Sukhdev sir's presentation. Dr. Kuldeep Sukhdev sir is a practicing pediatrician from Nagpur, Kingsway Hospital in Nagpur. So, and he will be presenting the case to Amravati, team Amravati. We have Dr. Shailesh Jaiswal sir, Dr. Shripat Jahangirkar sir, and Dr. Rohan Bogde sir. Please unmute yourself.
And you may start a screen share.
Sir, you can start your presentation, sir.
Right. So I'm sharing my screen. Is this screen available to all?
Yes, it's visible, sir.
Right. So first of all, very good evening from Nagpur. This case is neither to test anybody's knowledge, nor to criticize how this case was done up over the period of time this case was in any hospital. This is only for the discussion. Am I audible to all of you?
Yes,
Very
yes.
audible, clear?
Sir, can you do it full
Yes,
screen?
sir.
Please do it full screen.
Yeah. So there we are. All of you?
Yes.
Visible? So without wasting time. So a 5-year-old, this is the point of discussion is November 2021. So a 5-year then, with a date of birth of September 2016, a male presented to a hospital with complaints of, a very typical complaints of 2 episodes of generalized tonic-clonic seizures 3 days prior to hospitalization, and a high-grade fever started a day prior to hospitalization. In 2017, the child was hospitalized with H1N1 bronchopneumonia and seizure disorder. In 2020, the child was again hospitalized with complex partial seizures, probably because of left mesial temporal sclerosis. And then child was on levetiracetam. So what are the possibilities if the team is wanting to know somebody who has got hospitalized with a day of fever and seizures? What possibilities do they share?
The child is 5 years old and there was a history of fever.
Hello, Shripad.
Yeah,
Very good evening to
Good
you.
evening, sir. Good evening, sir.
Very good evening.
It will be a great time to learn from you. So I'll start with what I feel. At the end of history, the child is 5-year-old. There was a history of fever at the time of admission. So first, and we don't know details about the neurological examination at that time. So first will be a possible cause of febrile convulsion. But simultaneously, if the child has presented again with complex partial seizure in 2020, which was at that time, child was must be more than 5 years old at that time. And at that time, there was no history of fever with some abnormal MRI finding. So probably this could be a fever triggered convulsion, which I could look at in the retrospective manner. And
Right.
simultaneously, I would like
So
to know.
Shripad, the convulsions came fairly couple of days prior to fever actually. When convulsions started, there was no fever.
3 days back now.
Okay, so probably it could be a febrile convulsion, but fever triggered convulsion looks like a little bit better. And looking at now at 2020, we have got some findings which is abnormal on MRI. So definitely I will like to go ahead with some neurological examination and anthropometry and how is the development of the child at present.
Right. So as I can understand, convulsions came. He had 2 episodes of convulsions on a particular day, remained asymptomatic for another day, and then had fever. So he probably had an acute onset febrile illness, and seizure seems to be provoked by some intercurrent illness in a child, which we do not know, and a past history of seizure. So this is very typical once we have children admitted in a hospital, and if the disease is just ongoing, and we do not know what kind of things are going to come up in the future, there's very little we can have in our hand. So he had seizures because he had seizures in the past, and probably an intercurrent illness which triggered a convulsion. Okay, initially they were partial seizures, now they are generalized tonic-clonic seizures. On examination, child appeared after a day of fever. Child was toxic, irritable. On that day, even though he was febrile, blood pressures were fine. There were no significant systemic findings apart from in his CNS examination. Apart from being irritable, there was nothing else. Look at his weight, because this is going to come again and again in our discussion. He had a weight of 18 kgs, which was fairly more than 50th centile for his age, and a height of 105 centimeter. And on the graph, it appeared just below the 50th centile. And on the IAP graph, obviously the 2 lines which we see is 3rd followed by 50th. So I said 3rd dash 50th centile. So this is the, to make it small, this is first hospitalization, understanding that there was very little this child had, and probably he got hospitalized because the patient's family was comfortable with a particular physician. On that day of admission, CRP was 138.7, TLC was 7,700. There was some neutrophilia, electrolytes were normal, calcium was 8.8 on the lower side of normal, serum magnesium was 2.2. Anything which you get from here? Anything which helps you make any diagnosis?
Probably the counts were normal, 7,700 with neutrophil counts were more, and CRP was raised. But considering neurological examination, there is no definitive neurological findings like neck stiffness or any other finding. So CRP may be related to inflammatory response or stress related response. Electrolytes, calcium and magnesium looks to be normal. So at present, there is no possibility of electrolyte disturbances or calcium hypocalcemic conversion or hypomagnesic conversion. But definitely CRP is high. Either we have to consider as an infective cause or we have to consider another cause like inflammatory cause.
Absolutely.
Which can be of any other reason.
Absolutely, Shripad. Exactly. Every time I talk with you, this is the most intelligent answer. So presently we do not have anything which we can pick up from here, except for the fact that CRP seems to be extremely high. So if it is not infectious, it might just turn out to be some inflammatory disease. And just because we have a history of a day of fever, we just stand nowhere to make a specific diagnosis. If we were to talk to the relatives, we would probably be very vague in saying why all this thing happened. Probably telling them this child had seizures in the past and some intercurrent illness has again triggered it, and he has received Levipil in the past, and that is what he's going to probably receive now again.
2021, I will also like to consider this as either sequelae or some related to the COVID, because we
absolutely.
So a 6-year-old child with such a high CRP.
Right, Shripad, because that 7th November 2021 very glaringly written there, it tells us that we were living in abnormal times. He was treated symptomatically. Fosulin was obviously started, Levipil continued, and in view of raised CRP, intravenous ceftriaxone was started. We never know, this could have been meningitis or it could be something else, and antipyretics as per requirement. The hospital course, what happened then? Once the child got hospitalized, I understand something happened, and slowly the relatives started to turn their back against the physician because they said we just came with a history of 1 day of fever and see how things are going on and how my child is getting serious and serious. He continued to have spikes of fever, develop frequent episodes of loose stools. After 24 hours of hospitalization, treated symptomatically, and again and the other day the physician turns up in the morning for the rounds and uh, he finds the child is now having bilious vomiting, abdominal distension, and suddenly a large liver, which was not there when the child was hospitalized. Pediatric surgeon's opinion was taken, and he said there's nothing he can think of which looks like a pediatric surgical problem, and he said to manage it conservatively. A nasogastric tube was inserted, and GI aspirate was monitored.
Probably the worrying factor is bilious vomiting and abdominal distension, which are all pediatricians are worried about. Whenever there is a bilious vomiting, always take opinion of pediatric surgeon. Definitely, we will like to investigate in the form of whether there is some changes of obstruction on X-ray or sonography in this child. Hepatomegaly 4 centimeter may not be a very common finding. So again, this is important thing. 2 days loose motions. Maybe there can be some pathology related to GI because this is hepatomegaly and abdominal pain distension. Some peritoneal irritation might have occurred because of inflammation or because of ceftriaxone. Also, there can be loose motions. So I will take it in the both way, but definitely abdominal findings are worrying at present, other than some CNS finding related to convulsions.
Perfectly right, Shripad. Both of us are going together absolutely fine, and you are missing nothing. So exactly, consider that this child is admitted under you, and this is a horrible and horrendous turn of event. A child who just came with a day of fever, suddenly this child has started to develop absolutely different kind of presentation, and whatever you must have discussed at day one when the child got hospitalized, and to your horror, things are just moving away from you. So what happens? The ultrasound reveals dilated fluid-filled bowel loops. They said probably this could be an ileus, and slowly the child turned to be drowsy and tachycardia and tachypnea. CSF study was done. TS study was normal. Repeat blood investigations on day 5 revealed a raised inflammatory markers, and antibiotics were upgraded because this is a child who came fairly fine just with a fever. Slowly has started to become tachypnic. Respiratory distress has come, he has become drowsy. The things have started to now really go down and much away from how you were thinking that this child would have got better in another 2-3 days of fever, and then you could have sent him on Levipil. So what do you think what must have happened here now?
Most of the thing that we learned from pediatric surgeon, our friend, that if the CRP is raised and abdominal is distended, the probably there is no urgent role of surgery. We have to treat inflammation first, and there is very less likely to be the surgical cause in this child. But looking at the parameters, the child is going in tachypnea, tachycardia, with sensorium also decrease, not improving, and probably with say 5 days of antibiotics, still infection cause seems to be the higher side. But ceftriaxone is a very good antibiotic to cover most of the CNS infection. So I will like to say that either we are dealing with some viral type of CNS infection which causes inflammatory response and SIRS like picture with abdominal involvement also. But simultaneously, I will like to also work up for other causes of inflammatory marker, because if the TLC is normal and the CRP is increasing, probably may not be the case, or even after 5 days of the treatment, child is worsening. Either we have to step up the antibiotic, which we already did, but second thought has to be given, like what is the cause of inflammation, whether we are dealing with some inflammatory disorders or some other problems. So I will concentrate on this factor also.
Yes. So whenever we have
But day 5 of blood culture, we can get blood culture reports. If they were okay, then probably bacterial cause may not be there because counts were normal, and with 5 days of antibiotics, either patient should show some clinical improvement or lab improvement, which is not there. So considering that infective causes are slightly on the lower side, but we are considering some inflammatory causes.
Yeah. So the physician on his rounds discussed whether this is infection, whether this is some inflammation, or this is a pediatric surgeon's disease. So this is how it finally landed up, that we do not know, some infection, some inflammation, or a pediatric surgeon's disease, and the child deteriorated on antibiotic which was being given, and thus they upgraded the antibiotic. Now, these are some of those parameters. Take your time. You can see some of them. I can help you to understand this. TLC seems to be okay. CRP is increasing, and procalcitonin is definitely more than 2. So the hospital pathology department says that anything above 2 is sepsis, and anything above 10 is severe sepsis. Ferritin, are you okay with ferritin?
Here the TLC counts was, second report was increased, but third report also shows there was a normalizing CRP. CRP was increasing and WBC count and patient was not improving. So probably infective causes, we should think on a second line. We should also start thinking on some first line. Procalcitonin is slightly raised, but I will not say very significantly raised in this child. Definitely other reports like ferritin is raised, which also suggests there is some inflammatory marker which has been improving, may not be always infectious origin, but we have to think of some other causes.
But in many children, 5-year-old, 400.
D-dimer is also slightly raised. Triglyceride levels are low as compared to normal.
Yeah, so we now both have, we are upper normal on one side and lower on the lower side. Triglycerides, TROPI was negative. Now, why did they do TROPI? What do you say?
Triglyceride probably was done to consider, we get raised triglyceride levels, something in Kawasaki disease in early phase. So some other causes, there was a fever and child has got other symptoms also.
Right. The physician's team of doctors probably discussed that November 2021. This was when MISC
also.
So they got a TROPI done. They did a D-dimer. We see D-dimer is 8,160 and fairly high. So this is a very mixed table which we see. CRP is high, D-dimer is high. TLCs are quite okay. We are all right with 10,300. TROPI is negative. A mixed picture. We can't say this is MIS. And Shripad, you must have seen fair amount of MIS here in Vidarbha. And this is not how MIS usually comes to you.
Yeah.
Okay?
Abdominal
you always have
other symptoms not there. Probably this is not classical MIS. Either it is not only inflammatory, not multisystem, or not cardiac involvement.
Yeah. So when you start to make a differential diagnosis in your mind, somehow you are not able to add too many diagnoses into it, and you are not able to remove MISC from your picture entirely. So you are there not able to convincingly make a diagnosis at this point of state. So this is how I think we have discussed. So the possibility of infection, possibility of inflammation, all of these possibilities stay. You are neither ruling out these possibilities, neither you can confirm with any of those classical things. But that is how we land up. You see, how this child probably landed in sepsis or MISC, we do not know. One thing we know is the child came fairly fine to you, but in another 4 or 5 days, child went on to become tachypnic and started to receive high flow nasal cannula oxygen. So they became fairly sick by the time, and we were not able to make a clear-cut diagnosis. Okay, so but finally we have to start treating. This is how it is. This is the whole slide is for criticism. You can criticize the slide, but definitely add to what you might have thought could have been done. Child continued to have fever spikes and a multi-system involvement, a respiratory system because child became tachypnic, GI because there was loose motions, and there was then later on went on to have ileus, bilious vomiting, and a CNS involvement in a state. Child became extremely drowsy. Inflammatory markers show a rising CRP and a deranged D-dimer. They considered a diagnosis of MISC. Shripad, they started on IVIG, and because he wasn't improving after IVIG, they also gave Solumetrol. Gradually, after offering Solumetrol, fever disappeared, abdominal distension reduced, hepatomegaly reduced, his consciousness improved, RT was removed, he started orally, tolerated feeds, he was hemodynamically stable and got discharged. And he was discharged on a very small dose of methylprednisolone for 7 days, supportive treatment for loose stools, and obviously levetiracetam there. Are you okay with this, or there's something more which could have been done?
Child has improved on starting IVIG and prednisone, but that any inflammation can mostly will improve with that.
Fever can subside.
Fever can
inflammation
subside
can
with IVIG and methylprednisone. But definitely some GI problem will have to be considered again, because everything
Right,
doesn't
Shiva.
look good.
After several days of hospitalization, more than 10-15 days of hospitalization, and the child starts to relieve, the first thing is you are relieved. The child is now able to get discharged, and it is lingering in your mind that I do not have a good diagnosis.
Yeah.
The child might have improved. He probably improved because of the all jacket treatment of IVIG on one side and a methylprednisolone of an extremely high dose on the other side. But we know in the back of the mind something is not okay. He got better. He has gone home. He has started to do well. His bilious vomiting is stopped. But somehow something is not okay. And obviously, it is not okay because the slide says this is first hospitalization. So there must have been another hospitalization as well. But Shripad, you're absolutely fine. While you're talking, I assume that you are the doctor who have been treating him, and exactly that way you're talking.
Kuldeep sir,
Right.
we have been learning a lot from you since many years. So probably few good things have come to Amravati also with your lot of good advice and teaching.
But this is how it's a combined effort. Now there are two photographs. Can you see this boy before he got hospitalized? His mother gave this photograph. A beautiful chubby 5-year-old, and then there is this sick child. Can you see that photograph? Emaciated, and look at his a very bubbly cheeks on one side, and the other side he has lost all the fat. So this is two contrasting photographs. While I'm saying that on 15th of December, okay, that means hardly 8 or 9 days again after he was discharged, maybe 1.5 weeks later, he's again back, okay, with a generalized swelling. Now he has a swelling over his body. Even though he looks emaciated, if you go and touch his legs, you know that there is generalized swelling, and he is continuously having loose stools. The effect of steroid went off, and the loose stools continued there. He again had decreased oral intake. His fever started again, and he came back. Any inputs you would want to have?
There is a significant weight loss is there, emaciation is there. And patient has still having generalized swelling, loose stools for 10 days. And at present, we don't know the cause. At that time, we have got a loose motion, but they get control, abdominal distension, they get control. But looking at the emaciation, there has to be definitely some problem which is leading associated with protein loss and associated with the fat loss from the stools. So now we take this condition as this symptom as very significantly related to bowel, and we like to work this child.
Right.
So if the child has responded to the prednisone and IVIG, then still one of the differential can be inflammatory bowel disease, which used to get respond to any kind of steroids for some period of time. Or we have to work up for malabsorption syndrome, because this is not loss of weight in 5 or 10 days may not be a good sign.
Right.
So definitely either HIV has to be ruled out, or we have to rule out some malabsorption syndrome.
Right. Very good. I think you're almost there, or rather you are there. This is how probably we would start thinking. Now here are some of those very important.
Tuberculosis can present like this, weight loss, malabsorption, but acute presentation was not common in the tuberculosis. So maybe I don't think they will not respond to the IVIG or steroid also without starting acute.
Right. So here,
I don't think.
So here again, the second hospitalization. If you can see the leg, the leg almost tells you. Look at the leg itself. It is edematous. If you were to press there, a large pit could be seen there. Actually, the child came out to be lethargic, and anasarca was there. He had a pitting edema. Blood pressure was just on the lower side. No significant systemic examination findings, and weight had dropped down. In spite of the edema and anasarca, from 18.5, he has landed to 16.9. The effective weight could have been absolutely low. And as I understand, the physician probably saw the weight of 14 also after his edema disappeared with whatever treatment they offered. So the weight was somewhere around 14 or 15 kgs. Okay. Anything here to add? You're there, almost there. The thought process is exactly what the physician would have been thinking at that point of time. Shall I move ahead?
Whenever there is a significant edema, looking at the history and examination, cardiac causes, we don't think. Liver causes or nephrotic causes also we don't think, because there is no such history or edema eyes also. Then third cause, which has to be really work out at some protein loss, which is occurring at GI level. We have to work on that because there is no, till now, we don't have any finding except for liver was 4 centimeters in the first history. We don't do any finding to say that liver is involved. And on examination, we should have get some finding related to renal pathology in last two in hospitalization, which was not there.
Which was not there.
We are not considering most three common causes, but we have to look at some rare causes which is related to GI.
Fine. So now look at the salient investigation. Here, the white blood cell has phenomenally increased to nearly 23,000. His sodium was less. His total protein was disastrously less, 2.7. You can see albumin has gone down to the pit. His urine routine examination said that it is hazy and there are ketone bodies in it. CRP is 42. These are salient what the resident would do before the consultant sees. He has sent his EDTA and plane and got some of the basic investigations done. And when you come for the rounds, these are some of the basic investigations which were available. The salient ones are written here. The slides are made such that it doesn't complicate your mind. If SGPT, SGOT is not written, it means it is normal.
Sir, sorry to interrupt, but we will have 2 more minutes for the case.
Oh,
Okay.
right. So
we can proceed with for hyponatremia and albumin low.
Right.
Probably we have to think again of the same line.
Yeah, Shripad will run from here because there are
Yes. No
few
problem.
minutes left. And anyway, you are there. So congratulations, first of all. So what are the thought processes one can have when you have this kind of a presentation? Okay, now it is a subacute presentation. So it is an intercurrent illness. Again, I thought, or the physician thought, another intercurrent illness, this time diarrhea. He is presenting with a syndrome of Kwashiorkor, and now he's a case of recurrent diarrhea. Okay, for a postgraduate student or a young pediatrician, recurrent diarrhea itself is a big mess because now there are thousands of possibilities, and the possibilities now move from here. So he was treated symptomatically. His sodium was corrected. Albumin 20% was offered. His potassium was on the lower side. Okay, so this was a treatment offered again because the diagnosis was not there. Okay, or the thought process is going on, but concurrently you have to offer treatment. So this was a treatment offered by the team, and over a period of time from pediatric ICU, he received albumin swelling gradually reduced, his consciousness improved. In 4 days, child symptomatically got better, accepted feeds, and his sodium potassium went on to be normal. He was discharged and advised to take high protein and high salt diet because his sodium was less. Was this okay with you? Now you understand if a patient starts getting hospitalized under you again and again, they have very little, the respect for you starts to reduce slowly, that you're not coming up with a diagnosis. And we know that pediatricians can sometimes, fail to make a good diagnosis of recurrent diarrhea. Okay. Finally, the provisional diagnosis was he was in MISC and he was sick for a long time. And that's why he developed malnutrition and he developed a hypoproteinemic and so on and so forth. A vague diagnosis was made and patient was again sent home. 4 days he stayed, that is all. Okay. Now third admission, can you see this boy now? Absolutely, now the bones are jetting out. Look at this boy, how he was looking 1.5 months back. He comes back again after 10 days, 5 days of anasarca, decreased oral intake, again irritable, anasarca, pitting edema, blood pressures on the lower side, no significant systemic finding, and weight with edema. Can you see his abdomen jetting out? So he has anasarca and weight of 16.7 kgs. And a similar, Shripad, I'm stopping you from talking here because you are already there with your same diagnosis and same thought process because you're almost there. This is exactly what anybody would have thought. These are the investigation, and can you see horrendously albumin has come down to 1.1. Stool says few pus cells, few RBCs and fat globules. If you want to make any impression of this, it is okay. Otherwise, we'll move ahead.
But now at present we are suspecting multiple involvement of malabsorption.
Yeah, all right.
Protein is not absorbed, and some probably vitamins also.
So this is a lot of medicines. Now the child has received doxycycline, MCT, omnacotil, 10% aminoin, noradrenaline, his blood pressures are low, dopamine, albumin, and so on and so forth. So one realized that the moment you give albumin, is fine, he goes home. And slowly the albumin disappears after a few days and he comes back with the same symptoms. No new thing is happening. All right. The hospital cost again in ICU investigation again only reveals hypoalbuminemia, is put on albumin, swelling gradually reduced, is TTG and DGP, because this was the time a major diagnosis comes into the picture, and that's a celiac disease which can have almost hundreds of different presentations. This could be one of those presentations. TTG and DGP was sent and they came negative. All right. So the possibilities now, any possibilities which is coming in your mind?
Protein losing enteropathy, but we have to do a lot of workup for that, like
you're absolutely there. There is not much to think. We say that somehow the child is losing protein because such an expensive protein is being given and he loses it in another 7-8 days. And that is what about it. So he came with a syndrome of recurrent diarrhea. The clinical presentation is like a Kocher curve, and because he also has hypoproteinemia. I'm now Shripad, I'm rushing ahead.
Yes, sir.
So that because you're already there, so no point in discussing it again and again. So now there's a chronic history of loose stools, malnutrition, and this child got hospitalized in a tertiary quaternary hospital, all kind of facilities available. Endoscopy was done and histopathology sample was sent. What do you expect? 1 or 2 likely things which can come there? So you are there. I've already wrote it. It's a protein losing enteropathy. If you go into text, there are ulcerative disorders, non-ulcerative disorders, and you can stretch the discussion for almost 70-80 pages. Okay. So endoscopy reveals duodenal folds, very, very flattened duodenal folds. So they made a clinical impression. Is it celiac sprue, tropical sprue? And in view of if you must have seen, there's something which I did not tell you. But now, can you see the MCV?
94.
94.
Higher side.
So when I was discussing, I was telling you everything is all right. I did not raise that MCV for a obvious reason. So now it looks like that he has got celiac sprue or tropical sprue like thing. So and in the view of a raised mean corpuscular volume and endoscopic findings, a provisional diagnosis of tropical sprue was kept. He was put on doxycycline, which we have to give for 3 to 6 months, and RT feeds were started. He symptomatically started to improve on doxycycline, Folwhite, IV methyl cobalamin, syrup, Levipil, SMCT oil, and zinc supplements. Okay, and slowly the histopathology came. They said there is a villous flattening and Crp hyperplasia, and kept a diagnosis of tropical sprue, and this is the treatment of tropical sprue. So this child who came with recurrent diarrhea and in a very horrible situation probably came out with a tropical sprue. These 2-3 slides are a discussion of tropical sprue, and anything and everything can lead to tropical sprue. But Shripad, as we said, November, December 2021, it was also a time for COVID, and we cannot rule out that there is an association of tropical sprue specifically in poorer countries, okay, with some other viral illnesses, and you'll have to keep on adding the number of viruses. And now we can probably also add that COVID or post-COVID situation can also present with this kind of discussion. There is fair amount of discussion I can have here but we have lost the time. Ms. Shilpa is furious with us. We have taken too much of her time with her. And that is what I think. You are there. So it's not important that you make a diagnosis of tropical sprue. It is important that you can like an algorithm reach down to what is known as protein losing enteropathy. That is absolutely right diagnosis, Shripad. Congratulations. You get 101 out of 100.
One thing is sure, next time we get a problem, first thing we will do is call Dr. Kuldeep.
No, that's okay.
Dr. Thangavelu, sir, can you comment?
Really, I congratulate the team for holding the patient such time, 3rd admission, 4th admission.
Difficult.
That shows how much you are able to commit to convince the parents that you are going the right track. For a rarer disease like tropical sprue. First, what I understand is the initial percentage, just 1 day fever and seizures, maybe a febrile seizure. That was the one which brought the child to the hospital. What I learned from this case is child is presented with high inflammatory markers. I thought you are going to come out with an enteric fever, partial to enteric fever, because in the season of MISC, there are many tropical infections are covered under MISC. After some time only, after third or fourth day only, we realized that we are dealing with our old friends like enteric fever or scrub fever rather than the MISC. So under the cover of MISC, many things were buried. I thought you are going to come out with either a partially enteric fever presenting as a recurrent fever. But I never guessed it. This probably first infection would have been a Shigella infection. Hope the blood culture was negative earlier. Correct, sir? So there's not any proved tropical infection. Scrub typhus also can present like this, probably in the first week, but for the recurrent diarrhea and hypoproteinemia, I will think most in terms of topical infections, either enteric fever or scrub typhus. Scrub typhus also can present with hypoproteinemia, low sodium, and all that. With recurrent diarrhea, then I realized that is only an initiating factor. We are going through a child with malabsorption syndrome. Of course, I also noticed that B12 deficiency was pointed out by the high MCV. So multiple deficiencies probably due to malabsorption, but I never guessed as a tropical sprue. I thought probably an initiating infection. We are going to deal with the child with the inflammatory bowel disease, either Crohn's disease or ulcerative colitis. This is the news for me.
Yeah, so
Thank you. The lesson we learned is we can't label everything as MISC.
Yes.
And then tropical infections. And with repeat admissions, probably we'll have to revise our diagnosis. Thank you very much for an interesting case.
So the take-home message was, if the child worsens under you, one has to be absolutely gentlemanly, behave with them, because they would really kill you. Because they just came with 1 day of fever and things started to worsen and go down. So that's one of the take-home lessons here, apart from the fact whatever Shripad told here was absolutely right. Thank you, sir.
Thank you. We learned a lot from your case. Thanks, sir.
Thank you very much.
So please stop sharing.
Yes, sir. Thank you very much.
Next case.
Shall we move on to our next case?
Yes.
Dr. Kuldeep sir, it was a really very different case, because with the first admission, we could not say what it was, and it turned out to be topical sprue. So congratulations. So going on to our next case for today. So for today, our moderator is Dr. Sunil Shaitsar. He is a practicing pediatrician and neonatologist at Maha for the last 24 years. And the team to whom he is going to present is from Navi Mumbai. So Dr. Mangai Sinha ma'am, Dr. Satish Sahni sir, and Amit Saxena sir, kindly unmute yourself. Sunil Shaitsar sir, can you please share your slide?
At the outset, I would like to thank Maha IIP and IIP Raigad for giving me this opportunity, and all the best to team Navi Mumbai.
Thank you, sir.
Just a minute. Okay, so we'll start with the case.
Sunil, do the slideshow. Slideshow la click kar.
Okay, fine.
From beginning.
Okay.
Yes, done.
Okay, thank you, sir. We'll start with the case. Okay, so this is a 5-year, 7-month-old girl born of a non-consanguineous marriage, first in a birth order, brought by the parents with the history of fever since 15 days, abdominal pain since 15 days, and vomiting since 3 days, and abdominal distension since last 2 days. I think we would analyze first year only. So what are your thinking on with this history?
Sunil sir.
Yes.
So this is Dr. Satish.
Yeah.
Thank you, sir. Thank you very much for being a moderator for us. This 5-year-old, 7-month-old child who has been, I think, with the previous maybe as complaining with the fever from last 15 days, is presented with the abdominal pain and vomiting with abdominal distension. is likely to have pathology which is localized. The anatomy is a GI system, and localization is either
Okay.
upper abdomen, or there is a issue with the complication of the disease.
Okay, okay, perfect. So we'll see the history of present illness. The patient was completely all right 15 days back when she developed a fever, which was documented up to 100 and 101 degree Fahrenheit, which was responding to plain paracetamol. And child was active, alert, and playful in between the fever spikes, and as well as with the fever also. On the same day, she developed a vague generalized abdominal pain, which was mild in intensity, subsiding on its own. Hence, she visited local practitioner who prescribed tablet cefixime and syrup metronidazole. However, she had a persistent fever spike for next 3 days. One spike per day, intensity of the fever being same throughout the last 3 days, but abdominal pain was increased in severity and used to subside on taking antispasmodic. So she was hospitalized and started on injection ceftriaxone and metronidazole at local hospital. Her pain, fever subsided over next 3 days, and she was discharged after completing total 7 days of antibiotics, 4 days of oral, 3 days of oral cefixime, and 4 days of injectable ceftriaxone. She was completely all right for next 5 days, and on day 2 of illness, she presented with the reappearance of the fever and pain in abdomen. It was associated with the vomiting. Vomiting was non-projectile, non-bilious initially, but bilious from next day onwards. 4 to 5 episodes, moderate to large in quantity, no blood in the vomiters. On the day of bilious vomiting, child developed abdominal distension, which was sudden onset, slowly progressing, and there were no relieving factors. So this is the history of present illness. Now, how do you analyze? Your diagnosis will change or it will remain the same?
The most probably the etiology looks like an infective origin because the fever has started with that. Initially, fever was looking like a viral because you are responding to antipyretics.
Okay.
Child was in between, the fever was also normal.
Okay.
But over a time, the child is getting now the increase in the fever, and also there is a likelihood of now complication of the disease presenting as a acute obstruction of abdomen or acute obstruction of intestine because of your sudden acute onset of bilious vomiting with abdominal distension.
Okay, okay. So even our thinking process was the same. Now we'll see the remaining part of the history. There was no history of Cox contact, no history of any previous abdominal trauma or surgery, no history of oliguria, hematuria, polyuria, no jaundice in the past, no history of weight loss, no significant developmental delay. No significant past history. Birth history, she was first in birth order. It was term HGA child delivered by LSCS, cried immediately after birth, no NICU admission was required. Family history, not significant. Immunization completed as per schedule. No known drug allergy. In dietetic history, her caloric intake was 980 for the expected of 1,400 kilocalories, a deficit of 420, whereas protein intake of 26 for the expected of 35. So there was a deficit of 9 grams. So she was deficit in caloric intake as well as protein intake. Now, how do you summarize? Your diagnosis remains the same or it's different?
What is the current weight of the child?
The current weight is 12 kg.
12.
Yeah.
Amit?
So this child has begun with a history of fever to begin with.
Okay.
Responded partially with the medicines for some time. Maybe the medicines were correct or not correct. That's a different story. Whether the vomiting developed because of the medicines per se or not, that's again a different story. But the fact is that the fever appeared again after 5 days of stopping the medicines. Then the child developed vomiting also, which was initially non-projectile, non-bilious, but secondly became bilious. So suggesting some kind of a obstruction, either a pseudo obstruction or an acute mechanical obstruction.
Yeah.
Apart from that, the the history of dietary history also is significant, saying that the child is chronically not eating well. So there's some degree of malnutrition also that we are dealing with. So yeah.
Initially, when the child was admitted, the fever was significant, but it came down after the medicines or in 3 days. And it was only vague pain. So vague pain can be there in a viral also, because interfebrile period, the child was active, playful. So which would make me think that it was not a very serious thing at that time, and the child was good. And after the initial treatment, after 5 days, she was all right. And then when she was hospitalized, that is when the entire thing of obstruction, history of bilious vomiting, and the pain got worsened. So whether something was there which got partially treated, or whether that medication itself aggravated, is a part to see.
We'll see on examination now. Okay. So on general examination, she was conscious, alert, febrile. Pulse was 120 beats per minute regular, bilaterally equal, good volume, no radial or radiofemoral delay. All peripheral pulses well felt. Respiratory rate of 22 per minute with normal work of breathing. SpO2 of 97 on room air. BP was 90/68 millimeters of mercury in right upper limb in supine position. Her anthropometry wise, height was 105, which was between 15th to 10th percentile, and weight was 12.5 kgs, which was below 3rd percentile. Father height was 162, mother's height was 148, with mid-parental height being 148, and the target height range was around 142 to 154 centimeters. So this was the growth chart, which is showing.
Okay. So here the weight is much lesser than the height. So it looks like more of an.
So height is normal, but
it's like acute malnutrition.
Okay. So on head to toe examination, there's a pallor. Eyes were normal, no conjunctival congestion. ENT examination was normal, no pallors, no cyanosis, lymphadenopathy, clubbing or icterus. Skull spines were normal, genitalia were normal, no external congenital anomaly, no injury marks, skin on no rash was present. On inspection, there was an abdominal distension. Shape of the abdomen was globular with dilated veins seen over the abdomen. Umbilicus was straight and inverted. There were no scars or sinuses, no hernia, no visible pulsations. On palpation of the abdomen, it was soft in consistency. There's no guarding rigidity or tenderness. Liver is 2 centimeter palpable below costal margin, soft in consistency, rounded margins, no left lobe palpable. Spleen, kidney normal. On means it was not palpable. On percussion, there was a horseshoe-shaped dullness. On auscultation, bowel sounds were heard and there was no bruit. CNS examination was not significant. The child was conscious, alert, oriented. Higher functions were normal. CVS S1, S2 was normal. There's no murmur. On respiratory system examination, air entry was bilaterally equal with normal work of breathing. No adventitious sounds were heard. So what is your clinical impression now?
Clinical impression is a acute infective origin pathology.
Okay.
Apart from pallor and the dilated veins which was there, there is also some free fluid which is seen. But the liver and the other systems are seemingly normal.
Okay.
So
but there is a horseshoe-shaped dullness. So there is a
free fluid.
Yeah, so there is a free fluid in the abdomen.
So there is a significant free fluid in the abdomen.
Yeah, so significant free fluid was there.
Free fluid is there. The child is pale, he is malnourished. So there is some chronic etiology underlying which is going on for a long time. And it may have been precipitated by some acute infection which has come up, or it is just an acute presentation of a chronic illness. Sometimes tuberculosis also can present in an acute or subacute form. So free fluid in the abdomen will suggest, will tell us that there is absence of edema elsewhere. Like there is no periorbital puffiness or pedal edema, tells us that the etiology is localized.
Okay.
So it is more of an abdominal etiology, either a serositis of the abdomen or maybe a pressure of the back pressure changes of the liver sometimes can give rise to this kind of picture. Dilated veins of the abdomen, are they tortuous as well?
No, not tortuous.
And,
no.
Flow.
So not
They were just dilated. There were no tortuous.
So it's not significant,
not significant.
Just appearance which is there.
Yeah.
So I would
distension, basically distension has caused that.
Yeah, distension has caused that.
Okay. So I would think of a chronic etiology which is going on and maybe precipitated by an acute infection. That we'll have to see.
Okay.
One of the differences obviously in our country will be tuberculosis, underlying tuberculosis.
Okay, perfect. Even our thinking was same. We initially thought of basically enteritis with there's a septic paralytic ileus or some kind of intestinal obstruction. And so we continued with the same antibiotic and the patient was kept NBM. And these are the investigations on outside. They were done on 13th. Hemoglobin was 7.85. Total leukocyte count was 5,230 with neutrophils being 59 with lymphocytes of 20. Platelets were normal 2,87,000. ESR was 92. CRP was 6.94. Serum creatinine was normal and BUN was also normal. On admission, hemoglobin was 8.2 with total count being 10,100. Neutrophils 60% and lymphocyte 34%. Platelet 4,77,000 and ESR was 115 with CRP is 2.9. LFT was done. Total bilirubin of 0.2 with direct being 0.1, indirect is 0.1. Alkaline phosphatase was normal. SGOT, AGPT 32 and 18 respectively. Serum albumin was 3.1. PT, PTT and INR was done, which was also normal. So we have done the abdominal paracentesis. It was a straw color fluid. There's no hemorrhage. Protein was 4.9 grams and cells were 20 cells with more of a polymorphs, which was 75% with the lymphocytes 25% and gram stain, no organism seen. We have sent a gene expert of ascitic fluid also. So even we were so we have done a sonography on the same day. USG showed inflammatory narrowing of a terminal ileum and ileocecal junction with proximal subacute intestinal obstruction. On the same day, we had done a CT which showed circumferential wall thickening is noted at multiple sites of jejunum and ileum, causing narrowing of the lumen. Bowel loops in between these lesions show mild dilatation. Rectum also shows thickening as well as edematous wall. Moderate ascites as well as mild pleural effusion was noted bilaterally. So possibility of tuberculosis was considered. So still you think about tuberculosis or what?
Yeah, these findings will actually strengthen our diagnosis towards tuberculosis because circumferential thickening can be seen in tuberculosis. Partial strictures may be the reason why the child is getting intestinal obstruction. And in fact, anemia also can be explained by the fact that there is a distal ileocecal junction thing. In fact, the indices of the CBC would also have been interesting to see whether it's a megaloblastic picture or it's a dimorphic picture. That is one more thing that I would like to know. But
even the child is undernourished.
Sunil sir.
Yeah.
Well, here I would just wanted to make a point that the age group is little lower for the abdominal tuberculosis thing.
Okay.
One.
Okay. Yeah. True.
Second thing is
but,
the circumference lesions are very wide.
Yeah,
he was undernourished, but the child has acute malnutrition. She is not chronically malnourished. Height is very well maintained.
Height is maintained.
Height is maintained. Second is the circumferential lesions are very widespread, including if you consider rectum, that throws a light on more of inflammatory disorders like maybe Crohn's or ulcerative colitis like conditions. But the signs where we are getting inflammatory signs are two. One is platelets are rising and the ESR is also rising in this case. So these two things are little bit we have to keep in the mind as a tuberculosis versus I would say kind of a
inflammatory
bowel disease.
Inflammatory bowel.
Even our thinking was same. So we wanted to have a bacteriological proof of tuberculosis. So ascitic fluid gene expert was negative. We searched for the primary focus also. BAL was done. Routine microscopy was normal. Gene expert and culture sensitive was negative. So we have referred this case to the gastroenterologist, who has done the scopy where the rectum is edematous, but there are no ulcers in the rectum. However, sigmoid colon, descending colon, splenic flexure, transverse colon, and hepatic flexures, they are showing edematous mucosa, multiple small superficial ulcers, but there is no mucosal friability, no deep ulcers, no pseudopolyps are seen. So even small bowel was normal. Ileum was normal. Even ileocecal junction was normal. Cecum was normal. Ascending colon and hepatic flexure was showing only edema. There was and very small ulcers. So there were no pseudopolyp or there were no deep ulcers. So even his thinking was it was plain colitis, maybe an infective etiology, and along with secondary to it is there's a transmural whether it's a secondary peritonitis. So that was the thinking was going on, and the fever.
She has pleural effusion also.
Yeah.
Child has pleural effusion, so that indicates is a multi-system disease basically.
Okay.
Or it is a kind of a, I would say kind of a thing which is transitive in nature.
Yeah.
Okay. So most probably tuberculosis can have multi-system involvement, but the child is not having the other symptoms of any like I would say kind of a only abdominal symptoms are there, more of a not respiratory symptoms or other symptoms. In this child, I would like to know about two conditions. One is X-ray chest and second is blood culture of the child.
Meanwhile, we have got the culture of ascitic fluid, which has grown the E. coli sensitive to cotrimazole. We have started this patient on injection cotrimazole, and within next 3 days, she became febrile. Her pain in abdomen disappeared. She started feeding well. But again, on day 5 of antibiotic, she started getting the fever. And this was the picture of her hand. So there was a thrombophlebitis. We have taken a pediatric surgeon's opinion who has done the desloughing, and we thought the fever could be due to this. So we continued with the same antibiotic, but fever was persistent. So we repeated the parameters, and these are the parameters which was done on 1st of December. Hemoglobin of 7.3, total leukocyte count was 1,700, neutrophils were 68 and lymphocytes of 29. Platelets were 1,67,000 with ESR of 94, CRP was 57. And on 3rd, hemoglobin of 7.7 with total WBC count was 1,000, neutrophils of 34 with lymphocytes 64. Platelet count dropped down to 98,000, ESR of 142, CRP of 16.7. Your take on this?
Here the CBC seems to be showing a pancytopenia kind of picture, developing pancytopenia.
Yes.
And in fact, the total count.
Bicytopenia. Hemoglobin is nearly same.
Bicytopenia with rising ESR and decreasing CRP, like a more of a inflammatory feature basically.
And okay. So CBC is
continue.
And in the third wala CBC is actually showing pancytopenia with a febrile neutropenia kind of picture.
Yeah.
So that is one more thing: rising ESR, rising CRP, rising ESR and decreasing CRP. So that also has to be looked at. So some inflammatory process which is going on for a prolonged period of time, maybe a complication of an infection which is seen. Sometimes we might have to think about complications like maybe HLH or things like that, which might have pancytopenia. But we have to also look at whether hepatosplenomegaly is also increasing or not.
No, there's no hepatosplenomegaly. Liver was same. There's no splenomegaly.
Okay.
So we have done the further investigations.
Was any
HGOT of 281, HGPT of 191 with ferritin of 1946, procal slightly raised 2.56, fibrinogen was normal 252, and serum LDH was 2979.
Yeah, I think we have to think about post-COVID syndrome now. Where all things are going like inflammatory and the child is getting deteriorated. But only thing is the sepsis part, whether I would just wanted to ask from the expert, what is the role of this like Septran or cotraxamol in the GI tract infections? Because a typical organism can cause like this infective colitis. These are not usual one, but the child has developed E. coli, which should be a normal sensitive either to the maybe first line third generation cephalosporin or piperacillin tazobactam as ASBL producer. But as this child had developed an organism which was a very unusual one, and which is only sensitive to clotrimazole, that's just kind of I'm a little bit worried, and I'm little bit amazed also.
And initially, the parameters, the liver was normal. The liver enzymes was normal.
Yeah, no, he's developing like a.
Yeah, now it is.
Now the serocytes
all
with inflammation.
markers are increasing.
I'll give you only one hint. Is look at his ESR and CRP.
Yeah, so that is going in
ESR
terms
is
of
increasing.
So, how do you differentiate between the ESR means different condition looking at just ESR and CRP?
When the ESR is decreasing and CRP is increasing, we have to think about MAS. That is macrophage activation syndrome.
You said
okay.
What?
MAS.
Okay.
Macrophage activation syndrome.
Okay. ESR.
Okay. Now, when the ESR is increasing and CRP is decreasing, it is more of an inflammatory condition. Okay. So inflammation either localized one or the chronic inflammation, what we can think of. Like when the child should have
perfect.
Fibrinogen, and with the both are increasing, and that is a dangerous one when we have to think about post-COVID or maybe HLH like condition.
Yeah, HLH or even sepsis sometimes.
Sepsis also.
Yeah. Okay. So your thinking was perfect. Inflammatory process. So we have done this. Anti-DS DNA was done. Antibodies were positive. Anti-DNA antibodies were 46.3. Anti-nucleosome antibodies were positive. Anti-ribosomal antibodies were also positive. There was low C3, C4, and urine microprotein urea was there, which was 233. Urine creatinine was 22. Protein creatinine ratio was 10.6, and DCT was positive. So that was in a nephrotic, basically in a nephrotic range, proteinuria. Even we have done a thyroid function, which was also normal. So your thinking was perfectly all right. So this is a case of inflammatory like a SLE, where anti-DS DNA and anti-DS DNA anti-ribosomal antibodies were positive, and we have labeled as a SLE. Along with that, there is a SLE presenting as a peritonitis in a 5-year-old female child. There is a bicytopenia, there is a liver involvement, there is a hepatic dysfunction as well. So these are the further antibody studies we have done. They were normal, like anti-smooth muscle SM antibodies were negative, anti-smooth antibodies were negative, beta-2 glycoprotein were negative, and anti-cardiolipin antibodies were negative. Lupus anticoagulant were normal.
Any history of rash previously in this child?
No history of rash.
Joint pains?
No. There is no joint pain, no rash. Without joint pain and without rash.
No previous history of any jaundice or anything like that?
No.
So SLE, it might happen that these things evolve over a period of time.
Yeah, things evolve over the period of time. The most important thing is we have to keep a watch on CRP and ESR. These are the two laboratory parameters can diagnose different conditions.
Can I add one point? As you said, no, because it started, all depends on the duration. Probably child presents fever, abdominal pain, and loose stools for a period of 1-2 weeks. We think of tropical infection like typhoid fever. Same thing continues to 3 or 4 weeks, and then child is losing weight. So we think in terms of tuberculosis. Now, as he said, no increasing ESR, but CRP is not proportionally raised. That is mostly in favor of a collagen vascular disorder.
Yeah.
That is because raising ESR, but normal CRP is almost in favor of a collagen vascular disorder. There is also a picture of pancytopenia, which can also occur in collagen vascular disorders. Very unlikely to see an SLE starting with the bowel. What about other parameters? Echo, X-ray chest.
X-ray chest was normal, sir.
Normal.
His blood culture was also normal, sir, twice?
Yeah, blood culture was normal.
So
but the only thing is
probably an evolving collagen vascular disorder. How it is going to be turned, only time only will tell.
Yeah. Because he has never complained about kidney, any issues with the kidney.
Usual parameters are not there, except only two systems involved: hematological system and bowels.
Will you please stop sharing?
Yeah.
Dr. Thangavelu, sir, your comment.
So it's a really an unusual presentation, starting as an acute infection and then gradually moving into the picture of a subacute chronic disease where all the possibilities are considered: tuberculosis, HLH, and gradually evolved into all the features of pancytopenia where we thought of HLH, and then other problems evolved, thinking in terms of high ESR and CRP, and but it's a very unusual presentation of a collagenous disorder. Any bone marrow examination was done?
It was normal. It was not done. It was not done. Sorry, not done.
So in this case, if you want to consider the diagnosis of COVID, post-COVID syndrome, how we should go? This all inflammatory signs now we are getting post-COVID also. And one thing is, like child is getting deterioration, this can happen because of the secondary infection or sepsis also. So just I wanted to think about that also. Because his platelets and all this rising later on, but this decreasing later on, this can happen because of some kind of an infective process which has happened, either hospital acquired infection because child has been there for a long time in the hospital also. And second is she developed some ulcerations on the palms, that IV side, which can be lead a point for the sepsis.
But the features like pancytopenia and other features for collagen vascular disorder all shift this from intercurrent infection. Intercurrent infection probably will be localized to one issues and other issues may not develop.
Okay, sir. Okay, sir.
Actually, this child perhaps had a very erratic kind of a fever. Though we said that he was responding to your therapy, we really don't know whether it was therapeutic response or it was its own. That's one point. Secondly, as I understand the ESR-CRP relation, if ESR is low and CRP is high, that's mass macrophage activation, and that's usually because of low fibrinogen. If ESR-CRP both are high, usually it is infection or acute inflammatory conditions or even connective tissue disorder. But when you get ESR high and CRP low, that's very unusual because CRP is run through gamma interferon pathway, which is blocked in SLE. So SLE and JDM are two conditions where you get this kind of a combination, where ESR high and CRP is low. That was perhaps the only clue in this child. Otherwise, you would have been really searching. There was nothing else to see because bicytopenia, tricytopenia, which is again a peculiar feature of SLE. SLE, because of antibodies, mass antibodies, you have all pancytopenias coming at some point of time. But there, this ferritin was high, though the triglycerides were normal or low, which is unusual for macrophage activation and all. So with a normal triglyceride, with a borderline ferritin, not really very great. 1900 is not very, we have seen ferritin going to 5,000, 10,000, at times 1 lakh also. So not very great to call it as a macrophage activation. And on that background, perhaps with this combination of ESR, CRP, it was giving a clue towards SLE or JDM. JDM again is not so common. Again, SLE is not so common at this age. But we obviously from the primary history itself, we are looking at something unusual. So that's how.
What was the duration of the illness?
2 weeks, sir.
2 weeks.
2 weeks.
Again, 2 weeks is very too early to think about collagen vascular disorders unless the duration is long.
Can Septran also be a reason for the pancytopenia? Like Septran was started after that the pancytopenia started. So maybe bone marrow suppression because of Septran.
Good guess.
But acute, so such a short duration should not cause.
Very short.
3 days only.
Take some time.
Yeah. Vijay should have been there. He would have read all ESR, CRP and done the diagnosis.
Next time, Sunil would have changed the case in that case.
Sir, even there was the fibrinogen levels were normal in this patient.
Yeah, that's important. Fibrinogen level was normal in this child. So again, that's against macrophage.
Yeah.
Sir, are there any more questions, or do you want to comment any more? It was a really amazing case, sir.
How this
And to
case was
crack
managed,
this-
Mahesh? How this child was managed?
Was given Solibetrol course, pulsing 3 days, and then subsequently he was put on DMARD. Subsequently, he was given low dose steroid for long duration. That's right, na Sunil? That is how it was done, right?
Oh, yes.
Yeah. Yeah, Dr. Mahesh Kore is there, rheumatologist. He can give few comments on this. Mahesh, you are there. Mahesh Kore, Dr. Mahesh Kore. No. He's logged in to get the points only.
No way, Mahesh.
He's there.
Come on. Mahesh doesn't need points here. Come on.
Yeah.
अच्छा मला वाटलं तो आला का? Hi. He's there. Hi Mahesh, your comment.
This is a SLE at a very young age, so we should think of monogenic SLE and we should do whole exome sequencing in this child.
Okay.
So we'll get a monogenic SLE is a totally different disease. Monogenic SLE. It is a genetically driven disease. So we have to think of that. That's all.
It's interesting. Dr. Sunita, you can take over. Dr. Thangavelu, last comments and then Dr. Sunita will wind up and maybe Hemant is there.
Yeah. Both these cases are totally atypical one. So the lesson is we should also consider about atypical cases. See, it keeps on changing. No, once we see the child initially, as the days pass by, our differential diagnosis also widens, and we have to identify the cases of infective etiology or secondary to inflammatory disorder, and all possibility has to be considered and to be excluded. Beyond this, I don't have anything much to add to this.
So today we had very good 2 different cases which took a different turn later on. So it was a very good differential discussion. And thank you so much, Thangavelu sir, for adding your expertise. And I would also like to thank Dr. Taide sir and Dr. Jitendra Gawane sir for choosing the team, which have done an excellent work. Thank you teams for joining with us, and thank you to both the moderators. So for the vote of thanks, I would request Dr. Jay Bhandarkar sir to please unmute and give the vote of thanks.
Just one comment here, Shilpa. Just one comment.
Yes, sir.
I suppose
Yes, sir.
both the teams approached it absolutely the way any good pediatrician will approach. Dr. Thangavelu sir will accept that. Both of them came. First team came to a malabsorption. Second team came to a chronic inflammatory process. I think that's what, as a pediatrician, we should at least.
Irrespective of the diagnosis they reach, they were given the right direction initially.
Absolutely.
Right direction. Almost going par with the person's team who managed the child.
Absolutely.
Congratulate both the teams for going along with the management team, even though it is a very atypical presentation. Thank you for the opportunity to learn.
So this is all because of our seniors like Dr. Mohit sir and Dr. Yoli sir, who has been guiding force for us a long time.
हॅलो माझा आवाज येतोय का?
Yes, sir. Yes, sir. You are audible.
Okay. Thank you. Actually, both teams for these excellent cases and lot of churning of the thoughts, because the presentations time to time change, and approach was very good. So thank our first expert, Thangavelu sir, for his precious time given to this Maha IP, and as well as both team and all organizer team has helped for the, arrange this excellent academic event. Thank you. Please join in large number for other academic Maha academic sessions also. Thank you very much, and thanks to Dr. Sunita and Shilpa for excellent moderation also. Dhanyavad. Good night.
Thank you, everyone. Thanks a lot. Thank you, everyone.
Thank
Thank
you.
you, sir. Thank you very
Good
much.
night.
Thank you.
Thank you, sir.
Thank you. Thank you. Good night.
Right.